We will be starting this. Actually, we are very much, worried because of our connection. Last two times the connection was not good, so we could not complete more than 20 minutes or 25 minutes class. Okay, so I think this time we will be able to complete the salivary glands. First of all, we will be speaking about the technique of this salivary gland surgery, and this is not of very much importance to you as far as entrance this exam is concerned. Some of the bits might come for entrance examination, and some of them might be there for an understanding of anatomy, some of them for knowledge, and some of just one or two questions might come in the final exam as far as third year ENT is concerned. So third year exam, you might have some important questions like facial nerve landmarks. Anybody tell facial nerve landmarks? And phrase syndrome. Okay, facial nerve landmark, phrase syndrome, etc. These are all the important questions that might come in the examination. But as a whole, this chapter is only for understanding, and we are taking elaborately because we have time, and then we are going to understand the things. That's it. Understanding helps us in retaining the knowledge more better way, so that you can do things properly. So for any parotid tumors that you will be doing something called superficial parotid is one surgery which you are going to do. It needs facial nerve monitoring. Intraoperative facial nerve monitoring is important thing. It is useful for large tumors, especially the malignant tumors. So facial nerve paralysis is associated with malignancies of the parotid, because facial nerve is running between superficial and deep lobes. And also the revision surgery cases, you need the monitoring. So nerve monitoring is a device which is like an ECG. When you're connecting it, any problem is there to the nerve. If you are touching the nerve, it will show the indicator. It will show the indicator that the sound will come. Oh, you're damaging the nerve. So something, the indicator will come. So you should not damage that nerve. Sometimes you are going to do something called as retrograde dissection for the facial nerve. So you're doing something called as retrograde dissection for the facial nerve, which is done by the less experienced surgeons. That is, if you are taking this as a parotid gland and facial nerve is going like this, all the branches are going like this, like T, Z, B, and C. So when you're taking this as the branches of this facial nerve, you from here to back you go, and then you trace out the nerve. From the exit to the entrance, you go till the level of stylomastoid foramen. What is that called as? Retrograde dissection. Monitor is used, facial nerve monitoring is used before preparing and draping the patient. What is preparation and draping the patient? When you are putting the patient on the table, you are putting some cloth, and then you'll be putting some cloth around the neck also, around the head also. That is called prepping and draping. Okay, this is one terminology which you know for this particular surgeries. Of one of the others, prepping and draping. That is one technique which is related to the particular surgery. Okay. So what are the incisions that you are going to give? These are not very important for your level, but you can have an idea about lazy S incision. So what is that called as? Normally the parotid surgery, the name one thing called as lazy S. That is called as lazy S incision can be given for this particular parotid gland surgeries. So the incision that is given, where is it giving? Whenever there are incisions, so in your particular surgery or whatever it is, the subject, there is something called incision. You will be able to describe the incision. Where is it given? How is it given? It is given in the preauricular region, around the lobule of the ear. So preauricular region, around the lobule of the ear, around the lobule. This is the lobule of the ear. Towards the mastoid tip. Where is it going? Towards the mastoid tip. Towards the mastoid tip, it is going and curving back down. So from there, mastoid tip and curving back down to the neck crease. Once again goes to the neck below the angle of the mandible. So here will be the angle of the mandible. Is it or not? So how is it starting, how is it going, and how is it getting down? This is all the description of the incision that is to be given. If preauricular crease is present, it should be used. So preauricular crease, if it is present, it can be used. Any incision should be hidden. Most commonly, best cosmetic incision is a hidden incision behind the tragus, just behind the tragus will be going. Prior to making the incision, it is very useful to make a cross hatching. So when you are, for example, you are going to give incision like this, reverse of the blade, you just mark it like this. and then you do cross hatching. This is called as cross hatching, so that when you are putting sutures, you will be putting sutures at this point so that the skin will oppose properly. That is called as cross hatching in the region of lobule. When making incision, it is important not to bevel the blade. So in the post-auricular region, so it may compromise the skin in the region. Bevel is using the blade at an angle. So when you are using a blade like this, it is the tip that is touching the skin, it is okay. When you are using the blade like this with the angle, then it is a problem for that. So it is called as bevel. This is the incision for this facial nerve surgery. It is called as Lazius incision. Lazius incision. So it starts here and then goes in front of the tragus and then goes to below this, below the lobule, and then goes upwards and then comes back downwards towards the neck. So this is called as Lazius incision. Lazius incision. So what are the flaps? So once you give the incision, you will be lifting the skin like this and like this. You will be lifting the skin like this and like this towards the parotid. In the case, the anterior skin flap is raised superficial to the parotid fascia. It is raised superficial to the parotid fascia. It is raised superficial to the parotid fascia. So you have to leave the fat. You have to leave the fat on the flap. You have to leave the fat on the flap, and it is sometimes you will be damaging. That is called as buttonholing. So you will be putting a hole in the flap. So you should not do that. Buttonholing is not allowed. If hair follicles are seen, is getting too superficial. So if you are lifting the skin and hair follicles are seen, it is a too superficial thing. So what you do after taking the flap, after you giving the incision, you should do traction and counter traction. This is one thing which is done in the surgeries. Traction and counter traction, as far as the wound into possible, very helpful in defining the plane. When you are putting, so you use what is the instrument called as skin hooks. So there are something called as skin hooks. These are something called as skin hooks we will be using. We will be lifting this flap this side, this flap this side. That is towards the sky you should be lifting. So these all are there in the videos that we are trying to take for understanding. Skin hooks are also defined in a video, one of the videos in the ENT student, you can see that. Sometimes you can use scissors also, dissecting scissors also. If you use the scissors, you can use the dissecting scissors and then you can lift the plane off like this. So plane can be lifted with the help of scissors. And then cut the intervening fibers. Sometimes you can cut the intervening fibers. When your fibers, for example, skin fibers are there, you can cut these fibers. Especially in the neck, the flap may be raised either superficial immediately deep to the platysma. So in the neck, platysma is a muscle that is present more commonly in the lateral region. When you take the neck like this, so platysma is distributed in this manner, more commonly in the lateral region. And towards the level of, for example, if you take this mandible, till this level, the platysma is distributed. You can raise it superficial or deep to platysma. So platysma is a subcutaneous muscle. You should keep it in mind. Platysma is a subcutaneous muscle. There is a white line which defines the plane, and the surgeon needs to be usually apparent between these facial and neck planes. So white line will be there when you are trying to cut. A white line will be there. The surgeon should be confident with this. When raising the flap, it is the utmost importance that surgeon keeps palpating the tumor. So you have to keep on palpating the tumor and does not enter into it. So you should not do tumor spillage, something called as tumor spillage. You should not, whenever there is a tumor hidden below the skin, you should not puncture it directly. So you should be going all around it and then removing like a ball. That's the best thing. If you try to puncture, it leads to tumor spillage. These are the words that are used during surgery. You should know these words, okay? In the ear region, incision should be deepened along the cartilage of the external artery canal. So when you are doing surgery at this particular point, it should be deepened as deep as the cartilage. So cartilage, perichondrium should not be damaged. If perichondrium is damaged, it leads to perichondritis. So these are the words that you should be knowing. Perichondritis occurs. Perichondrium is damaged, perichondritis occurs. As long as the surgeon stays right on the external artery canal, he should be there at the level of EAC, external artery canal. The incision can safely be deepened all the way to the bony cartilaginous junction. So you know the cartilage outer 1/3 and then bone will be inner 2/3. So 2/3 and 1/3 will be the bony cartilaginous junction. As far as this is concerned, should keep it in mind about these things. The incision for parotidectomy surgical technique, the surgeon should look out for the tragal pointer. So I said, so what are the facial nerve landmarks? These are very important. Facial nerve landmarks. Facial nerve landmarks, they are very important. What are the important landmarks? Like cartilaginous pointer or tragal pointer. Okay, CTSP, I told you CTSP of which the cartilaginous pointer or tragal pointer is very important. T is the tympanomastoid suture, C is the cartilaginous pointer or tragal pointer. Important landmark for facial nerve. These are the questions that are asked in the final exam. These are 2 marks question, very important. 2 marks question. Cartilaginous pointer or facial nerve landmark. That is, write down tragal pointer. It acts like a pointer. Like this is the index finger. This is a, it shows like this. So this is called as cartilaginous pointer. So see the nerve there like that. At this point, surgeon should divide the tissue anterior to the mastoid process in order to join the dissection of the region of external artery canal, so that in the region of sternocleidomastoid. So he goes to the level of mastoid process. At this tragal pointer should divide the tissue anterior to it to reach the mastoid process. He reaches the mastoid process after doing the tragal pointer, and he reaches the mastoid process. Mastoid process is somewhere here, is it or not? And then join the dissection in the region of the external artery canal. This is the external artery canal region. So all these things have to be joined, and the mastoid process is reached means this is the sternocleidomastoid muscle. The muscle in the mastoid process is sternocleidomastoid muscle in the region of sternocleidomastoid muscle. At this point, the surgeon should divide the tissue. Already told this one mastoid process to join the dissection of external artery canal and also your sternocleidomastoid muscle. The depth of this should remain superficial to the digastric muscle. So when you take this one, for example, this is the mastoid process, this is the sternocleidomastoid, and when you take this as a mandible, from here to here, the digastric muscle also comes. So this is the sternocleidomastoid that is attached to the mastoid process. This is the digastric muscle that is attached to the mastoid process. So it is, the depth should be superficial. So it should go below the sternocleidomastoid and above the. So for example, there are 2 pages in the book, one and this is the second page. So first one is the sternocleidomastoid, second one will be the digastric ridge, digastric muscle. Okay. So once you complete the sternocleidomastoid, you reach the digastric muscle. Once you turn out this digastric muscle, you reach the facial nerve. You reach the facial nerve. The depth should be, it should be superficial to the digastric muscle. Where many blood vessels around the mastoid will require appropriate control. There will be blood vessels at that level. You should keep it in mind. How do you locate the facial nerve during this particular thing? So focus your concentration on facial nerve landmarks. So facial nerve is very important for you. That's why I'm dealing this glands in detail. But this is not a waste of time for you. You have to understand these things. Where does the facial nerve emerges from? Stylomastoid foramen. Facial nerve emerges from stylomastoid foramen. So where is it actually? Superior to the posterior belly of digastric muscle. Just superior to the posterior belly of the digastric muscle. Posterior belly of digastric muscle, PBDM. At the same depth as this muscle. So as you could see, so once you take the mastoid process, this is the styloid process. Facial nerve comes like this, is it or not? So styloid process is always medial. You should remember that styloid process is medial to the facial nerve. You can say this as a landmark. Styloid process is medial to the facial nerve. This is the mastoid process. So once you take that, you can have, superficially will be your sternocleidomastoid muscle, and deep will be your digastric muscle. This will be the digastric muscle. This is the digastric muscle. Yes or no? So sternocleidomastoid muscle and also digastric muscle. Digastric muscle will be there. You should be keeping this in mind when you are doing the dissection. So what about the tragal pointer? The tragal pointer is 1 centimeter superficial and above this point. So when you take this one, for example, from here to here, if this is the ear, for example, ear canal like this is the tragus. Tragal pointer is at a distance of almost 1 centimeter. You should keep it in mind. This is the tragal pointer and 1 centimeter from the distance. Tragal pointer is that way. The styloid process is medial to the facial nerve. It's not a good landmark. I already told you. So I already SPM. You should remember that styloid process is medial. Styloid process is medial to the facial nerve. Take the mastoid tip like this. Facial nerve will be like this. This will be the styloid process. This is a mastoid process. stellar process is medial. You can write SPM as simple as that. If you draw this diagram, it will be very good in the examination. Facial is a facial nerve. The direction of the nerve is anterior, superior, inferior. RC, if you remember, India is playing cricket with RCs right now, is it or not? RC. So this is a natural process, this is a stellar process. Once again, the anterior, superior, and inferior. It goes like this. Anterior, superior, inferior. It goes like this. Okay. Prior to looking the facial nerve, so before you get into the facial nerve in parotid surgery, you should look for the posterior belly of digastric and tragal pointer. Tragal pointer should be well defined. And the surgeon should have opened a broad plane of dissection. So there should be a broad plane of dissection. Never working a narrow hole is not allowed. So when you are looking at this one and this one, tragal pointer, this is a nerve, and this is the digastric muscle, and this is the sternocleidomastoid muscle. Sternocleidomastoid is digastric. Your plane should be a broad plane. It's not like a narrow plane. Narrow hole should not be there. Surgeons should note that from this point, the nerve is coming towards them. So from this point, when you take the stellar process, nerve is coming towards us. So towards them, that is towards the surgeon, the nerve is coming. The nerve is coming. The surgeon is standing like this and then doing the surgery. The nerve is coming towards the surgeon. There are usually many fibrous strands in the region of the nerve, which will need to be divided in order to find the nerve. So fibrous strands are there. Before you get a result, you have to do a lot of hard work. So this is the digastric muscle, this is the sternocleidomastoid muscle, this is the stellar process, this is the mastoid process. Many things will be there. All those things should be divided in order to find the nerve. In addition, there are usually some blood vessels. It's superficial to the nerve. So before you reach the nerve, there will be some blood vessels. If injured, will cause troublesome bleeding. It will cause troublesome bleeding, and identification will become difficult. So facial nerves identification is very important. Parotid surgery. What is the most important thing? Superficial parotid tumor deep. What is that? Facial nerve identification is the most important thing. You should keep it in mind. Facial nerve identification is the most important thing. You should keep it in mind. It is better to divide the blood vessels. So after cauterizing, you have to cauterize the blood vessels. You have to apply bipolar diathermy. However, surgeon must be certain facial nerve is not cauterized. Facial nerve has to be saved. Blood vessels have to be cauterized if they are coming in the middle. How do you follow the branches of the facial nerve? So you have to follow in a sequence, starting either superiorly or inferiorly. You start either superiorly or you start either inferiorly. To be inserted along the nerve and lifted away from the nerve and opened. So what is the maneuver that is helpful? Lift, following of order. Insert, lift, spread, and cut. The parotid tissue is removed in this manner. You should insert the forceps. For example, this is the forceps. You should insert it. You have to lift it up, and you have to open the forceps like this, and then cut in between. Insert, lift, spread, cut. Insert, lift, spread, cut. Insert, lift, spread, cut. ILSC maneuver. This is called as insert, lift, spread, and cut maneuver. So whenever there is tissue in the middle, you have to divide it. Little progress is made. The surgeon should remember that branches traced distally become more superficial, particularly the upper branches. So upper branches of the facial nerve, like temporal, zygomatic, are more superficial than lower branches. Temporal and zygomatic branches are more superficial towards the skin than lower branches. Upper branches are more superficial towards the skin. That is very important. So the dissection should commence over a branch which is clear of the tumor. So initially you have to clear the branch of the facial nerve from the tumor and proceed towards the successive branches. Slowly you have to dissect. Parotid tissue should be divided in the middle sometimes. Once two branches have been followed, the intervening tissues is divided. So that superficial part of the gland containing the tumor can be peeled. You have to peel and see the gland. surgeon may come toward the tumor both superiorly and inferiorly. You have to go see when this is the mastoid process, this is a styloid process here, and it is coming like this. All the nerve branches are coming like this, and parotid is over here. So you have to see the basal branches. You are going to go nearer, 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 and you have to see for the facial nerve, and you have to remove this tumor of parotid slowly. For tumors located in either in the upper or lower lobe of the gland, it is not necessary to remove the whole of the superficial lobe. The tumor is located either in the upper lobe, only a part of the tumor is removed, that is enough. The author is saying like that. It is possible to remove the tumor within an adequate cuff. You have to remove a cuff of the tumor based on which you have to save the branches. That is a common concept over here. So deep part of the tumor is applied to the branches. Deep part is directly more commonly related to the facial nerve. Surgeon should carefully separate the tumor from the nerve, taking care not to rupture the capsule. If the capsule is there for the tumor, the capsular rupture should not be there. If not, it leads to capsular spillage. It is called as capsular spillage. It leads to recurrences. Capsular spillage of the tumor leads to recurrences. How do you close this? After doing the surgery, a drain has to be kept for fluid leakage outside. A drain has to be kept in that region for fluid leakage outside. Otherwise, the wound will inevitably accumulate and saliva and serous fluid because it is a salivary gland. So, if you close it normally without a drain, the saliva will get accumulated and there will be swelling post-operatively. The drain should be left for minimum 2 days. Ideally, left for 2 days. There will be vacuum suction drain sometimes. You're putting a drainage here so that the fluid gets collected, and after 2 days, it slowly gets drained, and you have to remove it daily, and then you have to remove the drain after 2 days. For 2 days minimum, you have to keep it. Closure is based on surgeon's preference. So, what are the difficult cases in parotidectomies? What would you see as a difficulty? The deep lobe tumors are more difficult. Initially, you have to do the superficial parotidectomy as described before. After this, branches of the facial nerve has to be identified after you do, because facial nerve is like in between, like a place of a hook. This is a superficial lobe, this is a deep lobe. Once you remove the superficial lobe, you can find the facial nerve, then you find the deep lobe. The branches are separated and tumor is mobilized. The branches are separated and tumor is mobilized. The underlying tumor is then mobilized and separated from the deep tissue. Mobilized and separated from the deep tissue. It is usually easily accomplished. Then you can do, once you lift up the facial nerve, you can find the deep lobe of the parotid. Superficial lobe, this is the facial nerve, then this is the deep lobe. You can just leading to little more than enucleation. In that surgery, the surgery is not called as enucleation, it is more than enucleation. If you do more than enucleation, the recurrence rate is lesser. Similar to seen in enucleation performed by superficial lobe tumors. So enucleation is better even for the deep lobe. He is saying that enucleation is better even for the deep lobe. Enucleation is better even for the deep lobe. So the tumor is removed between the two branches of the facial nerve. Whenever there is tumor in between the branches of the facial nerve, you should remove that also. Particularly, especially in the buccal region. Especially, what is that buccal region? I said 2 joint Bhaskar Medical College is the mnemonic for the facial nerve. Is it or not? This is the buccal branch, especially this buccal branch, temporal, zygomatic, buccal, marginal mandibular, cervicofacial. Buccal region, there is a lot of branching and communication. Branching and communication. There is a lot of branching and there is a lot of communication. So sometimes you might have to sacrifice. If it is a carcinoma of the parotid, what situation you will have to sacrifice? Nerve is already eroded. Nerve is already eroded. This facial nerve is already eroded. You might have to sacrifice it sometimes. So how about in revision cases? Once again, already done surgery. Once again, you are going to revise the surgery. Second time surgery is called as revision surgery. It is one of the most difficult surgeries in the head and neck region. Usually, it will be necessary to resect the previous scar. Scar has to be removed. skin resection. Sometimes skin also has to be removed to reconstruct the defect. We should be ready to reconstruct the defect. If previous surgery compromised a superficial parotidectomy, previously first surgery done was superficial parotidectomy, branches of the facial nerve will be beneath this flap. So once already superficial parotidectomy was done before, you will directly find the facial nerve below the skin only, and the intervening parotid without any parotid fascia. The fascia will not be there in such situation, and it is vulnerable to injury while raising the skin flap itself. Revision surgery, you should be very careful because the facial nerve is just below the skin. Extending the previous incision and identifying the correct plane in the virgin tissue is very important but difficult and useful maneuver. So you have to understand the plane that directly facial nerve will be below the skin. So this is the skin and facial nerve will be there. Superficial parotid already done, therefore facial nerve will be directly exposed. You should be very careful in that situation. Main trunk of the facial nerve may be difficult or impossible because of the scar of the previous surgery. It is very difficult to identify the facial nerve. So it is necessary to identify the facial nerve and perform retrograde dissection is the best method. So you go from nerve to, so this is the parotid and this is the ear and this is the mastoid and this is the styloid process. For example, this is styloid process. So from here to here you go. That is called as, what is that called as? The only word you should know is retrograde dissection. This word is helpful in writing the answer for the facial nerve landmarks, retrograde dissection. Sometimes what is that RMB, retromandibular vein, if it is present still, it is a useful landmark in the marginal mandibular and cervical branches pass directly over it. You take this retromandibular vein, this is the retromandibular vein, above which, so the marginal mandibular and cervicofacial. Retromandibular vein is below and marginal mandibular nerve and cervicofacial branch, marginal mandibular branch of the facial nerve. This is MC, is it or not? BMC. In the BMC, it is MC. So M is marginal mandibular nerve, C is the cervicofacial nerve. This retromandibular vein helps us as a landmark in identifying the marginal mandibular and cervical branches which pass directly over it. So if we take this as the marginal mandibular nerve, above it they pass. That is the importance of this marginal mandibular nerve. If already the vein was damaged in the previous surgery, so where do you identify the marginal mandibular nerve? They will be asking you. Marginal mandibular nerve is identified beneath the angle of the mandible or crossing the facial artery at the mandibular notch in the inferior part of the mandible. So if you say this is the mandible, this is a coronoid process, this is a condyloid process. So marginal mandibular nerve is beneath the angle of the mandible. Where is it? This is the angle of the mandible. This part is the angle of the mandible. So you say TZ BMC, M is coming below the angle of the mandible. Marginal mandibular nerve is below the angle of the mandible. It is crossing the facial artery. If you can palpate your head, if you can palpate your angle of the mandible here, you can see the facial artery pulsations here. At this point, facial artery pulsations will be there. Crossing the facial artery at the mandibular notch at the inferior border of the mandible. It crosses the facial artery at the mandibular notch at the inferior border of the mandible. The cervical branch is below the marginal mandibular branch. So there is a variable arborization and anatomy of the remaining branches. So how do you know other branches? So temporal branch, which is there, I told you TZ BMC. We are talking about this TZ BMC. We already told about marginal mandibular. We already told about this cervical branch. Now we are talking about this temporal branch. This is a temporal branch. It crosses the zygomatic arch 1 centimeter anterior to the ear. So when you take the zygomatic arch, this is the zygomatic arch. It crosses below the zygomatic arch. It crosses the zygomatic arch 1 centimeter anterior to the ear and courses superficial to the deep temporal fascia within 1.5 centimeters of the lateral border of the eye. Today, this is the eyeball here. So what happens is this temporal branch crosses the zygomatic arch. It crosses the zygomatic arch. Where is it actually? It is at a distance of 1 centimeter from the 1 centimeter anterior to the ear and superficial to the deep temporal fascia. Where is it? Deep temporal fascia, superficial to the deep temporal fascia. Above the deep temporal fascia level, it is there. So superficial to the deep temporal fascia within 1.5 centimeters of the lateral border of the eye. So from here it is 1 centimeters and from eye it is 1.5 centimeters. But the distance of the temporal branch from the ear is 1 centimeter, from the eye is 1.5 centimeters above the level of your deep temporal fascia. And where is the zygomatic branch? Zygomatic branch crosses the zygomatic arch further forward. Okay, further forward. So T is the TMC. We are talking about the zygomatic branch. And about upper buccal branch. Buccal branch is divided into upper buccal and lower buccal. Buccal branch runs forward roughly 1 centimeter below the zygomatic arch. When you take the zygomatic arch here, so this is the ear and zygomatic arch. So 1 centimeter below the zygomatic arch, the upper buccal branch lies. So the upper buccal branch lies. So where is that upper buccal branch? Is 1 centimeter below the zygomatic arch. 1 centimeter below the zygomatic arch. And the lower buccal, where is the lower buccal branch? Towards the corner of the mouth. So if you take this as the mouth, lower buccal branch is towards the corner of the mouth. Okay, LB. You can remember LB is at the corner of the mouth. Lower buccal branch is at the corner of the mouth. These are all superficial to the masseter muscle. So if you take the masseter muscle, where is it there? Masseter muscle is there attached to the angle of the mandible. This is the angle of the mandible. Masseter muscle is attached here. These are all superficial to the angle of the mandible. So retrograde dissection of the facial nerve may lead to higher incidence of neuropraxia than traditional dissection. So there are 3 types of damages for the facial nerve: neuropraxia, axonotepsis, neuronotepsis. Neuropraxia is a pressure-related palsy, pressure-related palsy. You are going from the source, destination to source, there will be a lot of neuropraxia. That is when you are going to do the retrograde dissection. Retrograde dissection, it leads to a lot of palsy. What are the complications of parotid surgery? Of these, most important complication you have to know for exam is Fries syndrome. You have to know this one. Fries syndrome is very important for you people. Okay, rest all are okay. We are going to handle. Facial nerve injury is the biggest concern in the parotid surgery. Weakness may be temporary. It can be a neuropraxia or permanent due to transection of the nerve. Temporary is neuropraxia, permanent is transection of the nerve. Cautery related injury can be there to the main trunk of the facial nerve, or more commonly one of the terminal branches. Temporary weakness is almost in half of the parotidectomies. In 50% of the parotidectomies, there will be temporary weakness. It usually occurs more commonly in difficult cases like large tumors, if they are there. Facial nerve injury is there. Tumor located in the deep lobe, facial nerve injury is there. Malignancies, they present with facial nerve injury, and revision surgery also they present with facial nerve injury. So why is this neuropraxia is occurring? The cause is not known, but it is a result of the trauma and traction and heat and cautery and prolonged operating time. So neuropraxia is all due to all these reasons: trauma, heat, traction, cautery, and prolonged surgery time. Especially in the lower division branches, in particular the marginal mandibular nerve is susceptible to neuropraxia. So marginal mandibular nerve, as we have already seen, marginal mandibular nerve, where is it located? Just below the angle of the mandible. Just below the angle of the mandible, you should see. And if you take the retromandibular vein, it is above the retromandibular vein. So below the angle of the, if you take this as the angle of the mandible, it will be the marginal mandibular nerve near the facial artery. I already told you about this palpation and all. Facial artery, above the level of facial artery, it will be there. And you should be keeping it in mind because it produces the sensation of the lip. So lateral part of the mouth, lateral part of the lip, and lateral part of this orbicular varus is paralyzed because of this marginal mandibular nerve injury, and it leads to deformity very clearly. So number 1 is nerve injury, number 2 is hematoma. When you are doing a surgery, you will have hematoma. It is reported in 5% of the parotidectomies. Small hematomas should be evacuated promptly. So hematoma, if it is forming after surgery, you should evacuate with the help of a syringe. So hematoma can be evacuated, and it leads to possible pressure necrosis. It leads to pressure necrosis. When there is a blood collection below the skin, it leads to pressure and leads to skin flap necrosis. It leads to skin flap necrosis. Number 3 is, it is called as seroma or salivary fistula. salivary fistula. Salivary fistula can occur. There is a communication between the left out this one and then outside the skin. The saliva keeps on leaking onto the skin. That is called a salivary fistula. Fistula is an opening on both the sides, like a flute. Is it or not? After superficial parotidectomy, serous fluid leakage from the saliva and transected parotid tissue is an expected occurrence. Lasts usually for 5 days, few days. I'm sorry, 2 days. So that is why drain should be kept and at least for 3 days, 2 to 3 days. I already told about the drain that should be kept for 2 to 3 days. At this stage, the skin flap should have begun to adhere to the parotid bed, so obliterating the dead space. So something called dead space. When you remove the tumor from this particular parotid region, the space is dead. That is called as dead space. Excess space is there. Fluid can accumulate in the dead space. So after removing the drain, patient develops swelling underneath the wound. It should be aspirated. So drain is for 3 days maximum, 2 to 3 days maximum. We already dealt about this 3 days. Seroma usually resolve within serial aspiration. So what is the seroma treatment? Treatment of any seroma in the body is resolved with serial aspiration. Resolved with serial aspiration. Seroma resolves with serial aspiration. In case of salivary collections, drainage of saliva out of the drain site. So when collection is there, you have to drainage. You have to do drainage. Or to the wound, patient is not eating is uncommon. Any collection should be aspirated. When there is any collection post-operatively, you will be aspirating with the syringe. Just a moment, there is a shift of the place for some time. So that should be aspirated. Any seroma is there, should be aspirated. Pressure pressing is required sometimes. So what is that you treat for this is the pressure pressing, similar to the type used in otoplasty. So as you should see here. And most important for you people as to this is a must sure shot question in your exam. Whatever we are dealing is to understand this only. Whatever you are dealing is to understand this. So this freeze syndrome is often asked in the exam. Freeze syndrome or gustatory sweating, it is also called as gustatory sweating. Freeze syndrome or gustatory sweating. It is a phenomenon which develops after parotid surgery. After parotid surgery, the patient develops sweating on the side of the face while eating. When the patient is eating, he will have sweating on the face. So salivation and sweating are linked here. Why is it occurring? Because of cholinergic secretomotor fibers, secretory units of the parotid gland. They have new axons to innervate the sweat glands, the skin flap, which are responsible for acetylcholine. So whatever that was supplying the salivary gland, they are supplying the sweat gland. So what happens when the patient is eating? He will have sweating. Eat to sweat to fray. You can just remember like that. So the cholinergic fibers are supplying to the skin flap. So what is the percentage? 10% will have this gustatory sweating. So if they can give you a question as gustatory sweating or freeze syndrome. Freeze syndrome. You can just remember this one, very important. Almost imagine that you have got a question in the exam. So they will experience it, and then objectively 95% of the patient we can see. So sometimes patient may not be able to know, but we will be able to elicit in 95% of the patients. So how do you demonstrate this? By minor starch iodine test. Starch iodine test. So with iodine solution, you cover the skin of that particular region. After it is dried, the patient is given lemon sweet so that you stimulate the salivary glands. As a result of absorption of wet iodine by the stars, the affected area will turn deep blue purple, DBP, diastolic blood pressure. What is the color of this one? Deep blue purple. So after the iodine is given in that region, it becomes deep blue purple. Deep blue purple. Deep blue purple. So when does this Praise syndrome occur? It occurs in months after surgery, and sometimes it is delayed after several years also. So what is this color that is developing with iodine? Deep blue purple. This is a very important question. You have to understand this and then write this in exam. You will get 2 marks. So when you give lemon sweet and applying the iodine over there, starch iodine test. It is also called a starch iodine test. Wet iodine by starch, the affected area will turn deep blue purple. So whenever you have got wetness in that particular region, it becomes deep blue purple. Just remember that. It's also important for entrance examination. It occurs more commonly in extensive parotid surgery. If you are removing completely, then it's more chances for getting this particular freeze syndrome. Several techniques for preventing the freeze syndrome. How do you prevent the freeze syndrome? They say you have to raise a thicker skin flap, number one. Rotation of superficial temporal artery based temporoparietal vascular flap and superficial musculo-aponeurotic system and rotation of sternomastoid muscle. So what are the techniques that prevent the freeze syndrome is thicker flap you can just use, number one. Number two is temporoparietal vascular flap that you can use. Number three is superficial musculo-aponeurotic system flap you can use. Number four is sternocleidomastoid muscle flap. All these things that you can write these things. Nobody in the state will write. You will be writing this answer. So you will get a very good marks, almost 4 to 2. If you give it for 4 marks, you can write this one. Thick flap, temporoparietal vascular flap, superficial musculo-aponeurotic system, and sternocleidomastoid. These all will be helpful for you are preventing the what? What is the syndrome you are preventing? Freeze syndrome. Freeze syndrome you will be preventing. So there are disadvantages either for this technique, of course. So what are the other methods that you have to prevent this freeze syndrome is topical anticholinergics. Topical anticholinergics may be useful. So lead to, but there are some amount of anticholinergic side effects. Persistent cases, what would you do? Injection of botulinum type A toxin, botulinum toxin, anticholinergic. So it inhibits the neurotransmitter release and gives long-lasting relief and may be repeated if recurrent symptoms develop. So what is the treatment for freeze syndrome? Botulinum type A toxin. Botulinum type A toxin. Botulinum type A toxin. Keep it in mind. So that is very important. So what are the variations in surgical techniques that you should also keep it in mind? Techniques involving the, what are that I already told you this one, sternomastoid muscle flap into the parotidectomy defect. So whenever there is a parotidectomy done, the sternocleidomastoid is transposed to that region. So what is that? After removing the parotid, you have a lot of space. That space is being occupied by the sternocleidomastoid flap, resulting from removal of large parotid tissue. A superiorly flap can be based superiorly or inferiorly. You take the sternocleidomastoid muscle like this. It has to be superiorly based flap by dividing the sternocleidomastoid around 1/3 of its thickness to halfway down to the anterior border and rotating into the parotid bed. So you can just cut till 1/3 and then you can rotate this towards the parotid region. Sometimes an inferiorly based flap also can be used by dividing the upper end of the sternocleidomastoid by rotating into the defect. So upper end can be divided or lower end can be divided. So inferiorly based flap is used by dividing the upper end and rotating into the towards the sternocleidomastoid towards the parotidectomy defect. The rotated muscle is sutured to the zygomatic arch and masseter muscle. So they have reported improved cosmetics and also problem is clear from freeze syndrome. Freeze syndrome is also cleared. but subject to assessment it is difficult, and appearance of gustatory sweating between patients undergoing, not undergoing, there is a question mark. So already told that this is also a doubtful thing, but you can write it as sternocleidomastoid flap. On the other hand, the important function that is retained is greater auricular nerve function. So greater auricular nerve function is retained in the case of this sternomastoid flap. Keep it in mind. So this function is lost. So this greater auricular nerve function is lost. This is one important side effect of this sternocleidomastoid flap, and also damage to the 11th cranial nerve, this is axillary nerve. And it is also bulky, sometimes lead to masking of the recurrences. Recurrences are inhibited, not seen outside if you are using this sternocleidomastoid flap. What are the latest techniques for this periodontectomy? So endoscopic Sayal endoscopy is called as Sayal endoscopy. Endoscopy term for all the salivary glands is the Sayal endoscopy. It helps in the duct stones. It helps in the diagnosis of stones and stenosis. Stones and stenosis. It is especially used in submandibular duct stones. It is especially used in submandibular duct stones. Submandibular duct stones. Submandibular duct stones is very important. Endoscopy, Sayal endoscopy is done for submandibular duct stones. The submandibular orifice is first dilated using lacrimal probes, and then you induce using a CO2 laser and other means. So dilation is by lacrimal probes, and then you can use the CO2 laser. And then what is the mm that is used in Sayal endoscopy? 3.1 mm. Normally, what we use in our department is 4 mm scopes. Okay, 4 mm size. Okay, 4 mm one, but here it is 3.1 mm. Rigid telescope is inserted into the submandibular duct with saline irrigation. Calculi are identified and removed. That way, calculi are removed. This technique can be helpful for dilation of the strictures also. Dilation of the strictures also. Endoscope assisted submandibular cyalinectomy through 2 cm neck dissection. Neck incision is also being done. So when you are going to do the submandibular gland dissection, you can use the endoscope also with 2 cm. Neck incision has been reported. So what is the prognosis of these salivary tumors? Recurrence rates are almost 1 to 2%. For malignant tumors, always I told you, malignant tumors, the output is dependent upon stage and grade of the tumor. 10-year survival rate is 90% for T1 and T2, 74 to 84% for T3, and 33% for T4. So other factors are facial palsy, positive surgical margins, and stage and grade. So survival of the patient with the cancer depends upon stage and grade. This is all important for any cancer. You can just write down like this. So disease survival rate based on high, intermediate, and low grade tumors is 90, 40, and 50%. You can just say. So this is survival rate, and T stage and N stage is also important for prognosis. Survival is dependent upon grade of the tumor. Facial nerve palsy is an important factor always in parotid tumors. Perineural, I told you adenoid cystic carcinoma, it has got perineural spread. Skin invasion is also prognostic, and male sex is a bad prognostic feature for this salivary gland tumors. What is the key evidence that we have learned from these salivary gland and salivary gland tumors? So what is the diagnosis done is by means of fine needle aspiration cytology. You can say that FNAC is helpful for diagnosis. But accuracy, especially the sensitivity and detection of malignancy, there are few doubts about this FNAC also. Because of this, surgery is needed for all the tumors, especially for the histological examination. You want to go for biopsy means excision biopsy, you can go. You want to go for biopsy means excision biopsy, you can go for it. So what is the treatment for salivary malignancies? It is wide surgical excision. You have to do surgery only for these things. In the presence of functional facial nerve, whether it is functioning or not, it is important to assess this facial nerve for this salivary gland tumors. Microscopic invasion is there or not? So even when a salivary gland tumor is suspected that there is a microscopic invasion, so you should keep an eye on sacrificing the facial nerve. Sacrifice whether to do or not, you should keep it in mind. So sometimes you need to go for post-operative radiotherapy. I told you port is also needed. Post-operative radiotherapy for local control as sacrifice of nerve. So if you want to save the nerve, you can go for. If you want to save the nerve, you can go for radiotherapy. However, radiotherapy on distant metastasis and survival is unproven. It is still doubtful. What are the learning points from these lectures? 3 days of the salivary glands. So we are learning about salivary tumors are rare, very rare, and there is a morphological diversity. Almost 40 types are existing as far as pathology is concerned, and there is always a diagnostic confusion. We should keep it in mind. Diagnostic confusion. What is the most commonest tumor? Pleomorphic adenoma. Pleomorphic adenoma is the most commonest tumor of the salivary glands. It has got propensity for local recurrence and malignant transformation chances is there. That is called as carcinoma X pleomorphic adenoma. And meticulous surgical technique is needed. If time is there, we will go to pleomorphic adenoma management separately also. Most of the time, they are slow-growing tumors for local recurrence. The salivary gland tumors are very slow-growing for local recurrence, as well as distant metastases are also present. So long-term follow-up is needed because many recur. There is a recurrence chance. The prognosis depends upon tumor stage. Always stage is one word you can write in the exam. Tumor stage. Grade is also important. Prognostic stage is important. Grade is important, and differentiation is important. Salivary tumors do not respond as well as to radiotherapy and chemotherapy as other tumors. Direct radiotherapy and chemotherapy are not very much useful. Surgery is the treatment of choice. You have to do parotidectomy, for example. Parotidectomy. You have to do. Radiotherapy is only an adjuvant, added treatment, but not the treatment of choice. Facial nerve sacrifice or branches sacrifice, you have to go for preoperative paralysis for recurrent tumors and also grossly encasing and infiltrating the nerve. If facial nerve is damaged by the malignancy, you have to remove the nerve. You have to excise the nerve. That is the only rule. There is no point in saving the nerve. But microscopic invasion is not an indication for the nerve sacrifice. Not an indication for nerve sacrifice. Microscopic invasion is not an indication for nerve sacrifice. Microscopic invasion is not an indication for nerve sacrifice. Post-operative radiotherapy for high-stage tumors. When do you give? What are the indications of post-operative radiotherapy? High-stage tumors, positive margins, where facial nerve has to be preserved despite adherence to the tumor. Despite adherence to the tumors. So this is how we have learned most about this particular salivary gland tumors, and then we have got a lot. We have got a lot to be seen about parotids. Just have a glimpse about what the parotid tumors are. This is all surgical technique which all I dealt till now. For 10 minutes more, we can just think of how parotid tumors can be handled. So treatment policy about these things is, so pleomorphic adenoma, there is a chance of recurrence. Just run out the slides for 45%. What is the specialty of the pleomorphic adenoma? It has pseudopods like this one. The capsule is breached. So enucleation just is not enough. You have to have a sleeve of margin to remove this particular pleomorphic adenoma. You have to go for superficial parotidectomy. Enucleation is not enough. So 2 centimeter margin was okay. Recently 1 centimeter margin is also been used. So deep surface of the pleomorphic adenoma tumor capsule, it abuts the branches of the facial nerve. One important point you should be knowing. So you should take a cuff of parotid tissue all around. So if this is a tumor, including the normal cuff, you have to remove. So capsular exposure is one thing which is going to occur, because of which there is spillage, always chance is there. You should be very careful. Spillage is there, you should be very careful. But recurrence is not very much according to what we think, but you should still be very careful. If the pleomorphic adenoma is in the deep lobe of the parotid or in the parapharyngeal space, the operation performed to remove them is little better than enucleation. It's more than enucleation. Every time you have to go surgery in a parotid, you have to go for more than enucleation. Enucleation is not enough. You have to go more than enucleation. Surgical technique is very important. It prevents the separation of pseudopodia. I told you pleomorphic adenoma is going to have pseudopodia like this on the superficial surface. In case of deep lobe tumors, they have a more complete capsule and less tumor projections. Deep lobe will not have like this. Deep lobe will be something like a round one only in pleomorphic adenoma. That's very important. So there is one more word called as extracapsular dissection for pleomorphic adenoma. This is one new word that you should keep. Extracapsular dissection. This is a technically demanding procedure. Okay. So the incidence of capsular exposure and positive margins is not different from ECD and superficial parotidectomy. There is no difference at all. So what is something important is the tumor spillage. This is the word which you should keep it in mind, tumor spillage. And there is also a chance for recurrence in the pleomorphic adenoma. So what is this? Carcinoma is reported to 67%, that is ex-pleomorphic adenoma, carcinoma ex-pleomorphic adenoma. Patients should be counseled for that, should be keeping it in mind. So post-operative radiotherapy, I told you already about what patients you should go for post-operative radiotherapy. Even in the malignancies of salivary glands, surgical resection followed by post-operative radiotherapy is the treatment of choice. Surgery is for local control. So we are just skipping up all these things. Extent of the surgery is dependent upon site and size of the tumor. It is dependent on site and size of the tumor. So facial nerve whether have to be preserved or not, microscopic involvement, facial nerve can be preserved. Macroscopic involvement, facial nerve can be removed. So management of the facial nerve already we have seen. And if needed, N1 next, you have to go for neck dissection also. N0 neck, it is always controversial to do neck dissection. So radiotherapy is also given and adjunctive therapy is also given. All these things are not needed for you, therefore I am skipping this. But as far as the understanding of the recurrent malignancy, you should keep it in mind. Recurrence also there. They also need surgical therapy and they need radical parotidectomy. So there was superficial parotidectomy, complete parotidectomy. Third one is radical parotidectomy. Superficial parotidectomy, deep lobe also parotidectomy, complete parotidectomy, and radical parotidectomy. And surgical technique and all we have already discussed. So I told you phrase syndrome, never forget, patient or landmark also never forget. With this we tried to complete a total glimpse of this salivary glands. Especially this is important for you people in view of the facial nerve. Never think that it is a burden for you, because you should be able to, you could be understanding this more better because of your understanding of the facial nerve anatomy. Hello? Hello? Hello?
Yes, sir.
Yeah, I hope you are able to follow this. You'll answer questions now. Yes? So Fraze syndrome, everybody write as a short notes at your home. Please see the textbook and write as a short note. And surgical landmarks of the facial nerve also very important. And what are the names of the tumors of the salivary glands? You all should know. So that is I have gone in depth, but at the end of the day, you should know names like pleomorphic adenoma. Okay, and then this particular mucoepidermoid carcinoma, which is the most commonest in the parotid, and also adenoid cystic carcinoma and adenocarcinoma, carcinoma ex pleomorphic adenoma, facial nerve related landmarks, facial nerve related whether you have to spare or not, how do you examine for facial nerve, and how do you see for examine the glands, and what are the different landmarks when you are doing the facial nerve surgery, what is retrograde dissection. All these things you should have a basic idea. Third year student, if you are going to have a very good marks, you can go for this. Okay, with this I continue. I stop this class, end the salivary glands, and we'll go to the next tumors or deep cervical fascia. If possible, we'll go for the cervical fascia because we have completed the parotid and all. We can go for the cervical fascia in the next class probably, so that you can understand the anatomy more, so that you can help in understanding yourself about this surgical anatomy of this particular gland, salivary glands also. Why these are important for as an ENT student is you should have a mind that parotid gland is running just below the ear. Okay, so you should have the fissures of Santorini. Fissures of Santorini. What are fissures of Santorini? What are fissures of Santorini? Chanakya? Hello. Fissures of Santorini, foramen of Ashkill, all these are there in the ear otology. There is a connection between the parotid and this particular external artery canal. The infections of parotid and external artery canal are interchangeably. They go from one point to other point. That is the fissures of Santorini. Keep it in mind. That is there in the cartilaginous external artery canal. Okay, with this I am ending the class. Thank you very much for your patient listening.